Everyone, in this lecture we're going to cover atrial fibrillation, one of the atrial dysrhythmias. Welcome to CAS-RN, where I teach you about all things nursing. We're going to go over the causes of atrial fibrillation, what your assessment needs to look like and what you might find, and some interventions that can be done to treat this. The most common type of a dysrhythmia is atrial fibrillation. So as stated in the name, it is an atrial dysrhythmia. In this case, multiple pacemaker cells in the atria are firing, which is causing the atria to beat chaotically. So each of these cells is kind of just taking over and it's all beating all over the place. And so the muscle isn't beating in a synchronization and together. It's just randomly contracting throughout the atria. So this is what you might see on an EKG with a-fib. So as you look at this, you're going to see that there's no P wave and it's irregularly regular. So you're not going to see any P wave because the atria are not depolarizing properly. So if you need a refresher on a normal sinus rhythm EKG, please check out my EKG basics video. You will, however, see a QRS pattern because the ventricles are still beating properly. So because the atria is not contracting properly, it's not able to get the blood out of the atria and into the ventricles. And this puts the patient at an increased risk for both blood clots and stroke. And it also affects the cardiac output, dropping it by as much as 30%. Some of the causes of atrial fibrillation include cardiomyopathy, pericarditis, pulmonary disease, hypertension, valvular disease, and coronary artery disease. When you're assessing your patient, things that you might find are going to include anxiety, some possible clots, dizziness, fatigue, palpitations, and shortness of breath, as well as syncope. So really quick before we get too far into these other signs and symptoms that your patient may be experiencing, I want to talk about clots. So clots form when blood stops moving. When the atria don't contract all the way, blood can collect inside the atria and stop flowing, which can then cause that blood to clot inside the heart. So if your treatment causes the heart to automatically return to normal sinus rhythm without taking precautions, it could move that emboli from the heart into the rest of the body, which could ultimately result in a stroke or a heart attack or pulmonary embolism or clotting in one of the other extremities. So when you're looking at treatment options, it's very important to make sure that the emboli does not get forced into the circulatory system and cause further problems for your patient. So let's talk about some of these other symptoms. a-fib can decrease the cardiac output by 30%, which is very significant. So these other symptoms are symptoms that you're going to expect to see when the body's only getting 70% of the oxygen-rich blood that it needs. Your brain uses 20 to 25% of your oxygen supply. So is it really any surprise that your patient's going to feel dizzy or be passing out? So it makes sense that they have shortness of breath because their oxygen supply has been decreased so dramatically. So what I recommend that you do is as you're going through these assessments and following disease pathology, make sure that you understand why your patient is experiencing those specific symptoms because of the effects that that particular disease might have on other body symptoms. And then the AV node acts as a filter, which can slow down the atrial rate. So the atrial rate is going to be anywhere from 300 to 600. And then there's three types when that AV node acts as a filter because it's going to slow down the ventricles. So we've got the heart rate, which is going to be less than 100, between 101 and 149, or greater than 150. So if it's less than 100, it's going to be considered controlled. If it's between 101 and 149, it's going to be considered uncontrolled. And if it's greater than 150, it's something that's called a rapid ventricular response. So you've got your atrial rate, but then you're going to have your heart rate, which is that ventricular response that should be filtered if the AV node is able to act as a filter appropriately. So interventions that we might see are definitely medications. We're going to want to make sure that we're giving our anticoagulants to our patients because we don't want to push that embolus into the body. We're going to be looking at antiarrhythmics like amiodarone or we're going to give digoxin or beta blockers and calcium channel blockers, which are going to ultimately help slow down the heart rate. Then we might look at cardioversion. There's two different types of cardioversion that you can do. You can do it mechanical or medicinal. This one you want to make sure, because this should take your patient and put them back into normal sinus rhythm if it works the way that we want it to. And if we do that, then we want to make sure that we don't have any clots. Before doing a cardioversion, you do something called a transesophageal echocardiogram. And this is basically where they just go in and they make sure there's no blood clots in the atria, because we don't want to push those out to the rest of the body systems. So with the cardioversion, you've got mechanical or medicinal, and the cardioversion is really neat. You actually hook patient up to the electrical pads and you will shock them in hoping that it will reset the heart to be able to come back at its normal rhythm. And then we've got medicines that we can also push that are going to do the same thing. And then another option that we can look at is ablation. And this is where they go in surgically and they actually burn some of those pacer cells so that they don't work anymore, so that they'll stop firing that electrical impulse. Then always our nursing interventions. This is pretty much the same every time we're looking in our assessment. We want to make sure their level of consciousness, where that's at. We want to check and see if we can feel pulses. We're going to check our vitals, especially our heart rate and our blood pressure, because that's what's affected with this particular disease. We're going to give any medications as ordered by the provider. We're going to want to make sure we have a good IV access. We're going to want to make sure they're hooked up to an EKG. And then when we can, we want to, as much as possible, we want to make sure that we're educating those patients about the new medications, signs and symptoms, and then when to contact the provider or call 911. All right, let's go through and practice on this. So first off, we're going to start with our rate. We're going to go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. We're going to times that by 10 because this is a 6-second strip. We're going to say that our beats per minute are 130. Then we're going to check our rhythm. If you look at these without even counting the squares, you can tell this one is much bigger than this one or this one. Then we get another big one right here. So we're just going to say that this one is definitely irregular. Then let's look at our QRS complexes. We're going to come down here and we can count just like we normally would. We'd say 1, 2, 3, 1, 2, 3, 1, 2, 3. All right, so we're going to do 0.04 times by 3 equals 0.12. So that one's actually normal. Then with our PR interval, because there are no P waves. If you look at this line right here, there are absolutely no P waves. There's no P waves right here or right here. So we actually don't have an ability to do a PR interval because our P waves don't exist. And then if we look at our ratios here, again, we don't have a P wave, so we can't look at that. And we do have a QRS, but it's kind of unclear whether or not we have a T wave going on. Maybe there could be one right there, one right there, one right there. Okay, so we don't have this either. So looking at our rate here, we've got it at 130. So this is going to be uncontrolled. And if you refer earlier into the video, if it's between 101 and 149, then that's considered uncontrolled. If it were less than, if it was 100 or less, then it would be considered controlled. So in this case, it's uncontrolled. Okay, and we did state earlier that your rate could be between 300 and 600. So this is an example that might not always show up in the EKG. However, this just means that our AV node is doing what it's supposed to do, because our atrial rate would easily be between 300 and 600. But in this case, this is our heart rate that's showing up on the ventricles. And so these are our ventricles that are beating, but they're still beating really fast. We can see that it's irregular. There's not any regularity if we were to look from each R interval. And then we have our QRS complexes are normal spaced, but we are unable to see any kind of P wave because we're not getting correct depolarization and repolarization of the atria. There are a lot of causes of atrial fibrillation, also called a-fib, which include cardiomyopathy, pulmonary disease, hypertension, valvular disease, coronary artery disease. Okay, when you go and do your assessment, you're going to see a lot of things, but remember what this disease is doing. It's decreasing cardiac output by 30%. So how is that going to affect the rest of the body? We're going to have low blood pressure. We're going to have syncope and fainting. People are going to feel anxious because they're not feeling good because something's wrong. Okay, and then our interventions are going to look at what we can do to be able to restore normal heart rhythm, but we want to be extra cautious with clots, making sure that we're not throwing that clot into the rest of the body systems. Thanks for tuning in. Please help me grow my channel by clicking subscribe and follow below.